Ladies and gentlemen, our online distinguished guests and partners around the world, welcome to 2020 Smart City CTalk Online Healthcare Session. This year, CTalk sessions are taking place only virtually. CTalk is the platform for delegates and city representatives to share their values and visions. Our first CTalk healthcare session has brought a wide variety of smart city insights from leaders in Taiwan, Japan, Colombia to India. Taipei City Government, Dr. Shijie Huang, and delegates from cities worldwide will engage in the talks regarding discussions of smart medical applications and reflections in the post-epidemic era. Join the first CTalk healthcare session today are representatives from the following cities. Let us invite President of Taiwan Association for Medical Informatics, Professor Dr. Jianye Xu. Taipei City Government, Dr. Shijie Huang. Mr. Usuge Miki, Director of Public Health Department, Kobe City Government, Japan.
Hi, it's great to be here.
Hi. Ms. Jimena Duque, President of Colombian Federation of Software Industry and IT, Colombia. Dr. Bala Saha, Chief Architect of the Open Group, India. Mr. Primj Krishnan, Representative of Foundation for Commerce and Cultural Interchange, India.
Yeah, hi. Hello to all.
We will now take a virtual group photo of all the meeting delegates to capture this special moment. Representing Taipei in the group photo will be Commissioner of Department of Health, Taipei City Government, Dr. Huang, and Professor of National Taipei University of Nursing and Health Sciences, Mr. Shi, will be our moderator of the CTalk discussion today. City delegates, please look into your camera. We are about to take a screenshot. Ready, set, smile. Next, please put up your right thumb as we take another screenshot.
Oh,
yeah, right thumb. Ready, set, smile. Thank you for joining the group photo shooting. And now, let's invite President of Taiwan Association for Medical Informatics, National Taipei University of Nursing and Health Sciences, Professor Jianye Xu, to start our first CTalk healthcare session.
Okay, I would like to welcome everyone and especially welcome our panelists. Even in this COVID-19 pandemic situation, we can still sit together using the long distance connection to see each other and have talk together. It's a very wonderful event. So as we know, coronavirus disease 2019 is an infectious disease caused by a severe acute respiratory syndrome. Coronavirus 2, it was first identified in December 2019 in Wuhan, China, and has resulted in an ongoing pandemic. As of 22nd September 2020, more than 31.1 million cases has been reported across 188 countries and territories, with more than 961,000 deaths. More than 21.2 million people have recovered. So today we are very lucky here to get together here to talk about the session of CTalk. Today's topic is about the COVID-19 epidemic era and the development opportunities for smart medical applications. As we know, because of the COVID-19 pandemic, something like non-contact medication becomes important. Keeping tracking of personal health at any time and leading to high demand for physiological data monitoring and the electronic personal health record. Also using AI and big data analysis to assist in the prediction and diagnosis of infectious disease. Also using AI algorithms are introduced into medical research to accelerate the development process of new drugs and vaccines. So since the outbreak of COVID-19, Taiwan has made a significant contribution to the prevention of epidemic. There are many new technology systems that Taiwan developed in this period of time, and that can be provided to the world. Furthermore, if we can collaborate with other countries and using high throughput technology, we can develop rapid screening reagents and antibody tests, which will help in the epidemic. So we are very happy here, and so I think there are three questions we are going to talk and ask in this session. First of all is how to promote the public and the private joint effort in epidemic prevention works. The second question we are going to address is what kind of new ICT technology can be applied on epidemic prevention work. And the last one is, as we are going to know, we are going to facing that the COVID-19 epidemic will become a normal state. It will stay longer than we think. So what kind of technology and policy should be applied in government public health system? So let me welcome all our panelists again, and now we will start our presentation today. So, okay, let me introduce our first panelist, Dr. Huang Shijie, the Commissioner of the Department of Health, Taipei City Government. He has been a leader of the medical services of Taipei City, and also a very important leader in the prevention working group of COVID-19 epidemics. So today his topic of Dr. Huang is going to be information technology in COVID-19 prevention. Let's welcome Dr. Huang.
Okay. Greetings, ladies and gentlemen. I'm Shijie Huang, the Commissioner of the Department of Health, Taipei City Government. Due to the severe global outbreak of COVID-19, the life of our citizens have been greatly influenced. As the main department in charge of infection control of Taipei City, the Department of Health has faced many new challenges. Today, I would like to share with you how we improve our effectiveness in infection prevention by adopting information technology. Here is the outline of my presentation. I will begin with a brief overview of the global and the local situation of COVID-19. Then I will focus my discussion on how information technology has strengthened our capacity of disease prevention, specifically in 5 dimensions, including border control, case notification, community transmission prevention, healthcare system, and decision-making and logistics. After that, I will wrap up my talk with a conclusion. As of September 21st, 2020, the global cases of COVID-19 had reached 31 million and caused over 960,000 deaths. It is without a doubt the most severe emerging communicable disease in recent years. The total number of confirmed cases and deaths are 507 in Taiwan. Among them, 127 cases and 1 death are in Taipei. Compared to the global statistic, the spread of COVID-19 in Taipei is under control. The main measures taken to control COVID-19 include surveillance, medical treatment for confirmed patients, epidemic investigation, home isolation for close contact with confirmed cases, home quarantine for inbound passengers, and effective preparation and allocation of medical supply. Compared to the civilian other infection disease, the workload of COVID-19 control is larger, making it our most important task to be effective and precise in infection control. To more effectively prevent the spread of the coronavirus, we have developed and integrate multiple information technology systems into our effort. Today, I will go through the 5 dimensions of our COVID-19 prevention work and the 11 IT systems we deploy in this process. First, and the most foremost is our first line of defense at the border. Our border control dictates that all inbound passengers have to declare their health status, and those with symptoms are required to be tested. The information of those with symptoms will be imported to the smart quarantine multifunction system for local health unit to follow up and track their health status for the next 14 days. As of September 21st, 2020, Taipei City have tracked 22 more thousand inbound passengers with symptoms. Among the 1,094 people who were tested, 78 people were tested positive, giving a positive rate of 4%. Thanks to the smart quarantine multifunction system, we are able to monitor closely the inbound passenger entering our city. The second dimension of our disease prevention is reporting confirmed and tested cases. When our citizens seek medical treatment, local medical care institutions are mandated to report patients that meet the report criteria for COVID-19 or have tested to the system. When a case is confirmed, the Department of Health will carry out a series of measures, including epidemic investigation, contact tracing, health education, and environmental disinfection. As of September 21st, 2020, our report system recorded that Taipei City have reported 3,455 suspect cases of COVID-19, tested 70,901 people, and 127 out of which were test positive. After removing personal information that identify individuals, the reported data and statistics are published on the infectious disease research system and open data platform for public and academic use, which provide our citizens transparent and credible data to refer to. Third, regarding community transmission prevention, contact of confirmed cases and inbound passengers are our main target of management. Among them, contact of confirmed cases are at the highest risk of infection, and they are required to carry out a 14-day home isolation under our regulation. Meanwhile, the local health unit will upload the list of this individual to the contact tracing system and track their health status at least twice a day during their home isolation. Those which develop COVID-19 related symptoms would get tested. Inbound passengers are at the second highest risk of infection. And similarly, they are required to undergo a 14-day home quarantine under our regulation. Upon arrival, they have to fill out the home quarantine notice sheet, and the information they have reported will be uploaded to the epidemic prevention tracking system. The civil and the police administration will check in and track their health status at least once a day during their home quarantine. And those who develop COVID-19 related symptoms will get tested. To ensure people under home isolation and quarantine comply with the regulation and minimize the risk of community transmission, our electronic fence system uses mobile positioning technology to monitor their location and make sure that they remain in their quarantine area. Besides, to avoid nosocomial infection, we make sure that people under home isolation or quarantine with medical need visit the hospital under the arrangement of our health unit. For now, to access medical assistance, this citizen can call the hotline to apply for the arrangement. We are also developing the infectious disease management system, which will provide online application channel for medical assistance that will offer more convenient service to our citizens and reduce the workload of our frontline workers. Our results on community transmission prevention has been largely successful. As of September 21st, 2020, our system tracking 64,671 people under home isolation or quarantine in Taipei. Among the population, 85 individuals have tested positive, making a positive rate of 0.1%. The authority concerned have found 235 violations and received 2,064 file applications for medical assistance. Through the management of home isolated and quarantined population, Taipei have only reported local cases out of 127 total confirmed cases as of September 21st. And there has been no known large-scale community outbreak. Fourth, to evaluate the risk of infection, we keep close track of our patient traveling history, occupation, contact history, and clustering information, or TOCC for short. And it wouldn't be possible without our national health insurance system. When our citizens go to the hospital, the National Health Insurance Medical Cloud System automatically show record of whether the individual is or has been under home isolation or quarantine, work in high-risk occupation, have risk of traveling or contact. What is more, our telemedicine program now supports the population under home isolation and quarantine to minimize medical visit and risk of infection. We actively encourage medical institutions to set up to provide telemedicine service so that patients with mild symptoms have access to medical service without leaving their home. Now we have approved 18 hospitals and 92 clinics to provide telemedicine service, compared to only 2 hospitals with this remote capacity before COVID-19. As of September 21st, remote medical service has been provided to 214 individuals during their home isolation or quarantine. Besides, we have set up 3 quarantine areas in Taipei, which are Yangmingshan, Anxin, and Guanghuai quarantine site. This quarantine site had accumulated 2,580 residents, with 864 residing at the Yangmingshan quarantine site, 1,506 residents at the Anxin quarantine site, and 210 residents at the Guanghuai quarantine site. These quarantine sites are provided with comprehensive physical and mental health care by the Taipei City Hospital, which is based mainly on telemedicine and supported by medicine delivery service. Cross-division counseling, hospital visiting, and testing service are also in place if needed. In addition, psychological consulting sections are also available to mitigate isolation and quarantine-induced anxiety. To build up a comprehensive disease control network and support our commanding officers through swift decision-making process, we have created a dashboard of pandemic monitoring and decision-making, which integrate and connect data from hospital quarantine site and quarantine hotel. On the top of the dashboard, we can observe key statistics, such as number of reported cases, testing status, trend of trend of case increase, and supply logistic criteria. This data enable the commanding officer to grasp up-to-date pandemic status at once. On the left, we can see analysis for the hospital, quarantine site, and the quarantine hotel, and the visualized figures are presented in the middle. The dashboard also shows detailed information on quarantine site, including bed occupation rate, number of admission and release, number of individuals sent to the hospital, first-hand status of bed, and physical and mental health status and quarantine individuals, which has screened out high-risk cases and support and effective management of our quarantine site. Digitally connected, our network, our COVID-19 prevention has successfully woven together the hospital, quarantine site, quarantine hotel, and the local community. And we expect to extend this invaluable experience of fighting against COVID-19 to further healthcare service. Lastly, we initiated a big data project that integrates all the COVID-19 related data presented in a simply visualized material. The projects serve as an effective and a powerful reference in our leaders' decision-making process on important agendas such as the resource allocation, risk assessment, and the disease prevention effectiveness evaluation. The Big Data Center also observes and analyzes public opinion across the internet as a side reference of our decision making. Another key policy in regard to logistics is the face mask rationing policy that Taiwan kick-off started since this February. It aimed to guarantee that all the citizens have access to the mask at the pharmacies. However, the packaging process have added heavy load of work to our pharmacists. To lessen logistic burden on pharmacists and guarantee our citizens access to masks, the Taipei City government launched the ID-based face mask vending machine with multiple e-payment channels, making mask purchase a convenient process with much lower contact-induced infection risk. Based on our successful experience of developing face mask vending machine, Taipei City is advancing toward to developing a smart mobile model that incorporates cashless payment, ID-based registration, and the mobile service into the mechanism of resource allocation. We anticipate running this smart mobile model so that the goods and the supply could be distributed to our citizens without limitation of time and infection. According to the poll, approvals rate our successful surgical mask vending machine reaching nearly 90%. During the intervention, the digital meets the tongue express that affirmation of the effort by Taipei City government, saying that and I quoted that, "I would like to thank Taipei City Government Department of Information Smart City Project Management Office for working together the central government in developing the API interface ID-based face mask vending machine, enable the public sector to connect existing API resource with convenience store in a tick and make it easier for our citizens to put order and purchase masks." In summary, Taipei's experience of fighting COVID-19 shows how information technology has improved our efficiency, reduce human error and successful in precise disease control. The information of disease control is not only our daily work, but also our goal for sustainable development in the future. This is the end of my presentation. Thank you very much.
Okay, thank you, Dr. Huang. It's a wonderful presentation. And I think we will leave the questions to the end of this session. Okay. All right. Now I am going to introduce our second speaker, Dr. Rushike Miki. He's the Director of Public Health Department, Kobe City Government, Hyogo, Japan. Let me give a very short introduction to Dr. Miki. He is a medical doctor and a health innovation manager. He's a multi-talent doctor, consistently rewarded for success in planning and operational improvement, experience in data infrastructure and service design, communicative, professional working collaboratively with stakeholders to effectively solve the smart health challenging issues. He also designed and developed the IT system that enable citizens to manage their healthcare data in 1 year. So today, Dr. Miki's title will be Facing Frailty in the Midst of the COVID-19 Pandemic. Let's welcome Dr. Miki.
Okay, thank you for a nice introduction. I hope everyone's hearing my voice clearly. First, I'd like to emphasize the importance of establishing infrastructure that enables us to test new policies or technologies in fast and cost-efficient manner. This concept includes staying connected to a group of citizens who are willing to participate to proof of concept trial when it is ready. And in this presentation, I'd like to introduce the infrastructure that we established and show one example of a proof of concept study using that infrastructure as well as the future possibilities. Next, please.
Okay, next.
Okay, this graph shows global trends of Asian society. And as of this year, Japan has the highest ratio of older adults in the world. But other countries are expected to reach the same numbers by 2065 on the far right. In other words, Japan is the first country that has to deal with issues related to aging society. And this could be an opportunity for us if you be optimistic to catch this situation. Next slide, please. One of the big issues with aging society is frailty. And for those of you who's not familiar with the term frailty, it's a condition associated with aging, which puts older adults at various risks of declines in health, such as falls and hospitalization and even mortality. And the bad news is because frailty develops with aging, we all have to go through this stage sooner or later. The good news is, as it is mentioned in here, frailty is modifiable. It's mainly caused by a sedentary lifestyle. So, for example, by regular exercise like walking, you can prevent frailty. Next slide, please. However, this guy, COVID-19 pandemic, puts us in a difficult situation. Here's why. Next, please. Next slide, please. Can you go back one slide back? Okay, thank you. What this graph shows is the older adults are at higher risk of dying from COVID-19, especially for those above the age of 70. This is one of the most distinct and globally observed phenomenon of this disease. In this pandemic, older adults face a higher risk of death once they get infected, and therefore it is safer for them to self-isolate at home, avoiding unnecessary contacts. However, on the other hand, now they're putting themselves at the risk of developing frailty due to a decrease in exercise and social interactions. And as I mentioned before, frailty leads to a higher chance of false hospitalization and even mortality. Next slide, please. So what we need is the solutions without physical contact and something that's maintaining social connections and better yet, using scientifically valid methods. Next slide, please. Okay, now I'm going to change the subject a bit and introduce the infrastructure that we developed. In 2018, we set out to establish our city as a major hub for promoting innovation in the healthcare. And the personal health record, or I would just say PHR from now on, the PHR system provides a data infrastructure for such project. Next slide, please. Our PHR system was developed in 2019, and now it has over 5,500 users in Kobe from all age groups and provides them with several services, including a free healthcare app shown in this slide. This app makes it possible to collect various behavioral data, such as number of steps, what hours of sleep you've taken, or what have you eaten. And it provides tailor-made suggestions for healthy lifestyle based on their data. The PHR system offers a wide variety of healthcare-related information and help us look for participants for various proof-of-concept studies. Data collected through the system can be used for academic research purposes, and it can also be linked to other health-related information the city has on file. And very important thing, all data use is based on the individual consent. Next slide, please. Now I will introduce one example of proof of concept study that we conducted upon COVID-19 pandemic. In July 2020, we gathered participants from citizens registered in PHR system and started a new project together with a startup company called Moth. This project aimed to prevent frailty among older adults with an online course while staying at home. Next slide, please. This company offers a smartphone app connected to a wearable wrist or ankle band, which collects all kinds of information regarding body movements. The app itself offers a variety of educational materials and home exercise regimens designed to prevent frailty among older adults. Next slide, please. Okay, so this is an example of online regimen. First, older adults watch apps exercise regimen, and then second, exercise with the wrist or ankle band. And third, they can remotely consult with a physical therapist. So this flow enables for the older adults to exercise at home following an online course chosen for them based on the results of a preliminary tests, because they have to take a test at the first place. And all the exercise data is then collected via the sensor-equipped wristband, and the data automatically sent to the server. And thanks to this, users can check their progress in the app and consult with their physical therapist on a regular basis. And this cycle continues for 3 months, and both initial and final test results are then analyzed. Next slide, please. Okay, this is the screenshot of how the app shows the progress and results. To the left is monthly exercise reports, and to the right is the progress and comparison with other population. This app shows how many times you have exercised and what regimens you have been following, and changes in your results and comments from a personal trainer and so on. Plus, you can also share your results with family and friends. And there's even an online group exercise opportunity where participants can feel kind of connected to each other. Okay, next slide, please. And this is pre and post exercise reports. Not only testing feasibility of the project, we're also evaluating efficacy by collaborating with academic institute as a joint research. Pre and post test results are analyzed by researchers in Tokyo University to evaluate the effect of this online regimen at the same time. Next slide, please. And this shows the flow of the data. The participants use this IoT device, which is a wristband, and all the data are collected via app to the server, and the data are given to Tokyo University. And this is, sorry, excuse me. The top half is what we're doing right now. We are about to finish feasibility test, and we will be analyzing the data to see if we are able to maintain or even increase the physical function of the participants. And I was hoping to share the data, but it still not have the final results yet. So I can't do that, unfortunately. But once we confirm the efficacy at this point, then we will be following these participants in the future, maybe for next 3 to 5 years, and compare those who participated in this project and those who did not, so that we can empirically verify whether this project has led to a reduction in need for nursing care or maybe in medical spendings, something like that. And everyone think, well, how? And what makes this possible is the medical and nursing care claims record that the city office has, and the citizens who have given consent to link their data and use them for public health research purposes. And that's how the data is going to flow on the bottom half. The Kobe city government will give out claims data to Tokyo University, so in the academic institute, they can link the data to further evaluate and see the effect of this project. Well, at this time, it is true that this is only a proof of concept study by linking the acquired data to other information we already had on file. We'll be able to not only prove the feasibility of this project, but also validate its social value in the future. And again, the key to the success is the infrastructure and group of participants, citizens registered in this system. Okay, at the moment, it is almost certain that we will have to live with the novel coronavirus for another while. So we need to come up with the solution that can protect older adults. This is very important because they are the most vulnerable population in our society. While we certainly have to lower the risk of dying because of the COVID-19 itself, but we also need to lower the rate of excess mortality caused by indirectly related factors such as frailty. We strongly believe that the demand for technologies that will allow us to maintain social connections while keeping physical distance will continue to grow. And the data framework established in our city will let us easily test these new technologies in a time and cost-efficient manner. Therefore, we are determined to continue using our PHR system, which enables us to empirically verify both the feasibility and the efficacy of various projects to accelerate innovation in the field of healthcare. Thank you.
Okay. Thank you, Dr. Mickey. It's wonderful talk. So please stay online till the end of the session. We'll have a panel discussion at the end of the presentation. Okay, well, I'm also going to welcome Dr. Chi to join us as a new panelist. Dr. Chi is the Deputy Superintendent of Taipei City Hospital. Actually, it's a union hospital. Taipei City Hospital has more than 10 hospital union together. Their Taipei City Hospital has been built a very successful data transaction network. It has been a very successful example in the personal health record exchange and also medical record exchange. Dr. Chi is also a Vice Director of COVID-19 Epidemic Prevention Working Group. So I am very happy to have Dr. Chi to join us. I'm sorry, Chi Dachen. Okay, Dr. Chi to join us. And Dr. Chi will join us at the end of this session to discuss. Okay, so now I'm going to welcome our third speaker, Ms. Ximena Duque from Colombia. She's the president of Colombia Federation of Software Industry and IT. She's the Eco-Minister from ICESI University and the Master in International Affairs from the External of Columbia University. She has worked for more than 10 years in business operation organization and in the digital ecosystem in Colombia for more than 8 years. Currently, she is the executive president of the Colombia software industry and IT that groups the software development, entrepreneurship, digital industry, and the video games. Because she's in Colombia now, right? So because of the time difference, we cannot see in person. See her in person. So she's going to use a videotaped. Today. So let's see his video now. Okay.
Good afternoon to everyone. Thank you for having me here as in this special event. My name is Ximena Duque. I am the CEO of FEDSoft. FEDSoft is the Association of Software Companies of Colombia, and we have been for more than 30 years working with our companies in Colombia in order to strengthen the ecosystem. I would like to thank to the Taipei Computer Association for inviting us here, and also to this special event for giving us the opportunity to talk a little bit about how the health tech ecosystem is moving in Colombia. So I would like to start with my presentation, and I would like to start talking about how the Colombian software industry is nowadays in our country. So in FEDSoft, I would like to explain about what are our main purposes in the next slide. That today, our industry in Colombia represents 1.7% of our GDP. We have over 1,800 companies, software developers, and software development companies, and they create over 120,000 highly qualified jobs. When we talk about this 120,000 highly qualified jobs, we are talking about jobs related with the IT industry, software developers and related. We have two main purposes in our industry, and we work very closely with government and other actors of the ecosystem to make this real. The first one is that we want our industry to be the 5% of our GDP by 2025. We are very convinced that if we achieve this goal, our country will be more competitive. We will have a very structured digital economy, and also the well-being indicators might be growing in a faster pace. And the other purpose that we have is that 30% of the income of our industry might come from international and from exports. To do this, so we also need this type of experiences and alliances with international and with other countries, such as Taiwan. And that's one of the things that we have been working very closely with you through our partners here in Colombia in order to create more international alliances that can create our country as a software origin among Latin America and also among the world. Okay, so when we start seeing our industry figures, what we can see is that we had a higher pace in the growth of our industry when compared with other industries in our country. We have been experienced growth of approximately 16.7% annually, and this has been more or less constant during the last six years, more or less. Then, if we start looking looking for the number of companies that has been created in the last 5 or 6 years, more or less 45% of our ecosystem has been created in this time frame. Another interesting thing that we can see in our figures and how the development of our industry has been moving in the last years is that the growth pace and the growth of our industry has been led by the medium and big companies. Then we have a strong need to move forward in the growth pace in these micro and small companies, which are more or less the 90% of the number of companies that represent our industry. That's why in FESOFT we are organized, and I would like to explain more or less how we work in special units that are very centered in giving and providing our companies special programs in order to impact in their growth and also to close this competitiveness gaps that we have encountered during the years. The first one is competitive enterprises, where we are very focused on providing the right information and management skills in order to make our companies more competitive in terms of managerial management decisions. And we also work in order to provide them very potent, very hard mindsets to our companies. The other unit, strategic business unit that we have in FESOFT is global positioning. And global positioning is very related to this event or this activity that we have today. What we are looking with global positioning is to make our industry more international, to give our companies the right information in order for them to conquer international markets, and also to provide them information and exit cases and all the information of what is happening in terms of technology in other places, in order to have these good practices provided here in Colombia. And the other one, that it's one of our major strategic business units, is IT talent. I think that it's something that is happening worldwide, and it's that we have a strong gap in IT talent. And nowadays, the IT talent is one of the most needed talent in the world. We have been facing a pandemic situation, which has led us to the need of having more a global economy, a digital global economy, and the needs for human talent and IT talent has been growing faster. So where we work here in IT talent is in three strong strategies: quantity, quality, and relevance. And then what we do in IT talent is that we work very closely with this education institutions in order to provide them information and to create special programs that can lead our companies to receive the right talent at the right time. Then, if we start talking about the health tech niche in Colombia, I would like to start talking about what we have encountered in FESOFT. FESOFT has created a health tech niche, and we call it vertical. And we have found that our companies, our health tech companies, are very competitive, and not only here in Colombia, but also in international markets, because our law here in Colombia is rapidly changing and is very complicated, if we can call it that way. So what we have here is that the software solutions and products that our companies are creating for the health ecosystem, not only here in Colombia, but abroad, are very robust. That's why we have a very good ecosystem when we are talking about the health tech industry. That's why we have created a group in FESOFT that is created and has been where 50 of our companies are specialized in health tech solutions. They provide more than 2,800 direct jobs. And when we talk about these direct jobs, we are also, again, talking about IT talent-related direct jobs. 40% of the hospital beds of the country are covered by our solutions. And they have also presence in Colombia, Latin America, US, and Europe markets. This is very important because one of the needs and the opportunities that we find with Taiwan is having the opportunity to create alliances. Our companies are more oriented, are more focused on software development solutions, and they are not very focused on hardware. So what we can, or where we had found opportunities is in having this relation created, as I know that Taiwan is very, very competitive in hardware, in order to have more complete solutions that can lead us to IoT devices. If we have like a closer look to where in our country are located our companies, we can see that they are more located in the center and southwest of our country. 71% of our companies are located in Bogota. Bogota is our capital city. 16% of our companies are located in Cali and Popayán, which is more located. There are main cities, and they're more located in the west and the southwest of our country. And 12% of our companies are located in other regions. And when we start looking at, on where they are providing these services, or which type of services they are or products they are providing, we can see that 71% of these solutions are offered to the public sector, where technical support, process consulting, custom software, data hosting, big data, and training are the main services or products that have been offered. And 95% of these solutions are also offered to the private sector. We can see like private sector is very, very important for our health system, where hospitals, pharmaceuticals, and insurance companies are their main clients. And technical support, process consulting, custom software, data hosting, big data, and training are the products and services offered by our companies. When we start talking about what has been happening in our country, we are and before COVID-19 has come as a big issue in Colombia, we have been talking about interoperability and how this might work in our country. And this is very attached to the citizen digital file and electronic medical record. As you know, and as happens all around the world, the medical record belongs to the patient, and there has to be a previous approval when having this interoperability and this movement of the information from one medical institution to another. So our country has created a law very related to interoperability, where they had established 12 months to adopt this interoperability system and to prepare all the ecosystem in terms of the guidelines and what they have to have ready and provide to the system and to the health system in order to work. And we have also adopted a platform, an Estonian model, which is called X-Road. And this is like the health and all the interoperability system of Estonia. And Colombia has adopted this system in order to provide this big interoperability project that we are hoping to have ready by 2021. So with COVID-19, what we have been experiencing in Colombia is that the health system and the health ministry has been focusing more on how to monitor and create special isolations and see how the virus has been evolving in the country in order to attack it more closely and create better decisions. What we have been experiencing here in Colombia is that e-health and telemedicine has been growing rapidly. We haven't seen this in years before. And we have been also experiencing some laws that have become more open. With telemedicine, what has been happening is that our government has created a law that can reduce all the requirements that software or that health tech industry has to provide for telemedicine to work in Colombia. But that is something that has been happening during the pandemic time. What we are looking for and where we are working nowadays is in providing the right information to our tech industry in order to make this sustainable. What we want is, once the pandemic is over, to have telemedicine as one of the main industries in our country, and we can only make it possible if we provide and if we strengthen the health tech industry, and if we prepare them for the post-pandemic time. So this was the information that I wanted to provide in this special event. I would like to thank everyone for having us here. I would like to strengthen the alliances and all the relationship that we have been creating during the years with Taiwan and with Asian countries as well. And well, feel free to write to me, to talk with us if you have special inquiries. And well, I wish you the best in this special event.
Okay, thank you, Ms. Ximena Duque, and her wonderful video. I think we already hear some of the keywords like telemedicine, interoperability, and global collaboration. So that I think we'll have lots of topic we can discuss in the panel. Okay, so let me introduce our next distinguished guest from India, Dr. Pallab Shah. Hi. So let me give a very quick introductions. Dr. Shah is the Chief Architecture at the Open Group and the President Association of Enterprise Architecture India. Dr. Shah has been identified as the thought leader by IBM Smart City Connect and featured by Forbes magazine. And he is also senior leader expert in enterprise architecture and a visiting professor of digital architecture at the Indian Institute of Management. Dr. Shah advised various ministers and states on matters operating to government-wide architecture initiatives. He has been a key contributing author of the India enterprise architectures. Especially, he has been a member of the high-level committee involved in the development of India's national digital health blueprint for the Ministry of Health and Family Welfare, Government of India. His work has been used as a primary reference of the SDG, Digital Investment Framework by the International Telecommunication Union, Union Nation, and has also the ITU's thematic report on digital transformation. Okay, today Dr. Shah is going to give us a presentation on Toward a Smarter Platform, India's National Digital Health Mission. Let's welcome Dr. Shah.
Good evening, everyone. I hope I'm audible to everyone, and can we get the slides, please?
Okay, it's already there. Yeah, the slides on. Yeah. 你要给他看到。
I'm unable to see the slides.
Yeah, okay.
Yes. All right. All right. So, as you can see, I'm going to take a bit more architectural approach in my presentation today, and this will gel well with the previous two speakers and some of the concepts that were talked about by Dr. Mickey when he spoke about the co-basicity, and Ximena when she was presenting about the health tech in Colombia. So I'm going to take more of a more architectural perspective to what we are doing in India to address some of the health challenges and the health priorities that we face. Next slide, please. Yes, so first couple of slides, I'm going to give you a general introduction to what is happening in India today. So we are in the midst of a major whole of government transformation. As you can see in this slide, it is not specific to healthcare sector. So I am coming to the healthcare sector a few minutes later. But what is important here is that when we do a whole of government, transformation, we are looking at how to improve the quality of life of the citizens, and the importance of architecture, to basically design systems and address some of the challenges which we face, not just limited to health sector, but even other sectors like agriculture, like education, like commerce and industry, so on and so forth. So this slide shows you the basic, building blocks of what we are trying to achieve through the whole of government transformation, digital transformation. And as a country, we have a target of $5 trillion of digital economy by 2025, which is about 5 years from now. So there is already an economic target that the country has set. Next slide, please. And in doing the transition, we typically use this approach as our methodology, so to speak. So first, we try to understand what is the context and what is the situation we are trying to address. So for instance, in the current situation, it may be addressing the pandemic priorities. Second is the second step there is to understand what future we want to obtain, what is the vision, what are the goals, what are the objectives we are trying to achieve. The third step is based on the context and the situation analysis, and based on what we have defined for the future, we come up with a strategy and a roadmap. And I think you've seen some elements of that in the previous speakers. And finally, it goes forward with a implementation. So that's a very simple, if you will, a simple approach to what we do when we talk of digital transformation. But what is more important is at the bottom, what we do is we try to align whatever we implement to the United Nations Sustainable Development Goals. Now, I'm sure some of you or all of you are already familiar with what the Sustainable Development Goals are. Next slide, please. Now, this slide shows you, so on the top right are the 17 Sustainable Development Goals. I'm sure you've seen that picture before, but what is important in this is that these 17 goals have 169 targets and 241 indicators. Now, what is very critical in this in this approach that we are using in India is that we don't look at the Sustainable Development Goals in isolation. We know that there are goals pertaining to, let's say, poverty, which are which affect our health outcomes, for instance, or there are goals pertaining to climate change, which can help, which can even impact health outcomes. You're trying to see the wildfires, for instance, in California. There's a climate change problem which can have health impact. So the takeaway from this slide is that we use the Sustainable Development Goals as a basis for integration. So when we say that we want to have a digital way of integrating systems and technologies, there must be some kind of a basis. And in India, we use the SDGs as the basis. Next slide, please. So coming back to the health, so obviously given the context here is health, so we are trying to move from e-health to digital health. And I know that we do have a panel discussion later on. And one of the questions that is assigned to the panel is that what kind of technologies are we trying to use? So you can see there, I've put it on a box there. So the use of analytics, the use of AI, robotics, machine learning, Internet of Things, so on and so forth, cloud, API-based integration are some of the major technologies being used to achieve, digitization of health services. Now, as I said, this is a subset of the whole of government transformation slide, which I showed you earlier. But given the focus in this session is health, so I'm going to focus purely on health. And let's see how this is being addressed with our National Digital Health Mission. Next slide, please. So talking of COVID-19, I hope this is the kind of trend we have for COVID-19. So we have many countries across the world have gone through international travel restrictions. There have been restrictions to events and public, public coming together. There have been school closures, so on and so forth. Now, while all of us cannot predict what is going to happen after stage number 5, which is full lockdown, but hopefully in a few months, we will be getting to a point where things will be a little bit more, stable, and hopefully the curve goes down. Having said that, what is important is that I think this is very common across all countries. The current pandemic in the past 6 to 7 months has accelerated the adoption of digital technologies. That is something which is probably one of the plus points of the pandemic that we have faced. People are now more open to consuming digital services. Next slide, please. Now, This has also created and identified and amplified some major challenges in the healthcare ecosystem. Number one is people, citizens, patients, so on and so forth, they have greater demands and expectations from their governments. We do know that a large country, a very large country like India, where there are multiple levels of government, it's a large population, it's a large country, it's a diverse system. There are lots of silos and fragmentation that go across the government. So it's very difficult to get a nationwide interoperability. It can be, it is possible in a very small country like Estonia, but in India to achieve a nationwide interoperability is a huge task. Costs of health, interventions are increasing across the world. I think that's a global phenomenon. We have seen that. Our technology, not just limited to India, but across the world, I've done a lot of surveys across the countries also. Our technologies are not able to catch up because the demands are increasing much faster than the supply of technology. And many times when we're looking at it at a sectoral perspective, there is a lot of competing demands coming from the hospitals, the healthcare facilities, the pharmaceutical companies, the citizens, the governments, the regulators, so on and so forth. So there are a lot of competing demands, and sometimes these demands tend to be conflicting. So it's important for us to understand what do we take as the priority. So these are some of the challenges that have gotten amplified in the past 7-8 months as a result of the pandemic. And therefore, we as a country, we decided that we need to take a national approach, a holistic and an integrated approach to look at healthcare. And we have come up with something called the National Digital Health Mission. Next slide, please. The National Digital Health Mission tries to address very fundamental questions that are equally important. But the more important part here is that how can digital technologies address some of these questions? The questions can range from how do we improve patient experience, quality of care, and safety? How do we integrate, care across settings we don't control? Because remember that when you're talking of digital health, it is not limited to the government ecosystem. It includes the private sector also, where we don't have much control over that. How do we do more with less? How do we create more value for patients, payers, and the community? How do we deliver care in the right setting? And how do we find enough qualified people to deliver increasing demands and requirements? So these are some of the fundamental questions we are trying to address in the National Digital Health Initiative that is currently underway in India. Next slide, please. Now, this is an architectural view of what we have created. So right at the top is defining the business of healthcare sector, so to speak. So it looks at identifying different patient apps, providing healthcare systems, connecting your primary health center to secondary centers, to tertiary centers, coming up with health programs and schemes, so on and so forth, including the insurance companies, where most of the insurance companies belong to the private sector. However, given that we are looking at it from a sectoral perspective, therefore, they need to be part of the ecosystem. The second layer there is talking about the application architecture. What that means is what are the common applications, what are the common solutions that are required to create this digital platform, to create this digital ecosystem. The third one is a very important element. I think Dr. Mickey has spoken about the personal health record, which is highlighted there, PHR account. But what is important is that given the largeness and the complexity of the country that we are talking about, India, we have deliberately decided to take a federated approach. What that means is that the data does not exist at the central level, because typically when you talk of central control over data, there is a lot of pushback from the local governments, which I think is common across all democratic societies. The local governments and the local facilities want to be able to control the data that they have been having access to for the past 30, 40, 50 years, right? And the bottom layer there is the data architecture. This is where we talk of identifying common data archives, common data hubs that are reusable across all the applications to provide the services on the top 2 or 3 layers, which you see in this picture. Now, when you talk of data architecture here, it can talk of registries of doctors, it can talk of registries of facilities, registries of pharmaceuticals, registries of patient health records, so on and so forth. So there are many things that we have put there, and this slide actually highlights some of the key components and building blocks of what is important. Now, for us to achieve a digitized platform, we know that we have to therefore come up with an integrated data approach. Next slide, please. And this slide shows you how we approach that. Now, typically, and I'm sure this is true in many countries, our data is very specific to a specific application. They do not interact with one another because they were never designed to interact with one another. So what we have done here is, therefore, we have created metadata and data standards, and therefore use that standard to combine data and therefore track the SDG targets and goals that I showed you earlier. So, for instance, there may be a sustainable development goal, specific to health, which may be pertaining to, let's say, infant mortality rate. Those can be used, when you combine data from different systems as a way to integrate. And this is the slide you need to link it back to the SDG integration. So what kind of data needs to be integrated is, that answer is provided by the SDG slide, which I showed you earlier. Next slide, please. This is an example of how the integration happens. So right on the top, you can see the sector we are talking about. It's a health sector. The line after that talks about the goal that we are addressing in this example, SDG 3, that is good health and well-being. Now, remember SDG 3, if you are familiar with SDGs, it also provides the targets. So you can see in the next layer, the targets that we are addressing, 3.1, 3.2. So there are specific targets provided by the United Nations that are relevant within this sustainable development goal. Now, to achieve that target, there is a certain specific digital service that needs to be provided, which is exactly what is highlighted there in the third layer, government to citizen service, care services for mother and child spanning the prenatal and postnatal periods, resulting in a healthy mother and child. So that's the digital service that we provide. Now what we have done here is the bottom 3 steps. We have elaborated that G2C service, health service, into specific steps of the use cases. So you can see it's a 7-step use case, all the way from linking the patient or the person there with a community health worker, all the way to step number 7, which is recognition and incentive for participation. So those are the 7 steps, if you will, of the business process. We have elaborated the business process in the bottom step, and very importantly, right at the bottom, you see a layer called reusable building blocks. So these are the software building blocks we have identified as part of the architecture, which I showed you one slide back. So these are the reusable building blocks. They are required to realize this use case, this digital use case. Now, your question would be, how do these reusable building blocks, which you can see as Lego building blocks, how do these work together? So we are using an API-based approach to get these blocks to work together, so that we are completely oblivious to fact is who is providing that building block. It doesn't matter whether it's a government entity or a private sector startup who provides the building block. As long as the API is exposed and it follows our standard, we are going to be able to use it to provide this digital service. So this is an example of how we are using the architecture to basically identify a digital service aligned to a specific SDG, but using reusable building blocks to realize that digital service. Next slide, please. So in doing this, we are moving from basic, building of systems to creating ecosystems. And through the National Digital Health Blueprint, our aim is to be able to build a open ecosystem, open digital platform, which allows not just the government entities, be it hospitals, be it primary healthcare centers, be it pharmaceuticals, be it insurance, be it banks, to participate, but also startups and IT service providers, technology companies, product companies to also participate in the platform. So as you can see, the important part here is to use open technology to enable everybody to participate and become part of the ecosystem. Now here, this is actually my last slide, but what I want to highlight here is that this is the approach we have not just taken for healthcare sector, but we are taking for other sectors also, which may not be relevant in this context, but it is just information for you to understand. So we are taking a similar approach for agriculture. We are taking a similar approach for education. We are taking a similar approach for, commerce and industries. So eventually what we want to achieve is this whole of government digital transformation is a platform of platforms. Right, so this is the health platform that we are building at this point, and I've given you one example. Similarly, there are other platforms being built so that overall we get to the point of a digital economy, a digital society, and achieve that target that I spoke about earlier. Next slide. Yes, so thank you very much. I hope that gave you a quick summary of what we're trying to achieve with the specific example of healthcare sector. Thank you.
Okay, thank you, Dr. Peleb Shaha. I think Dr. Shaha gave us a very comprehensive blueprint of federated digital health in India. Thank you again. Okay, next I will introduce our last speaker, Mr. Pramithi Krishna. Okay. Sorry. Okay, Mr. Krishna joined Foundation for Commerce and Culture Interchange (FCII) in 2014 as India a representative that act as the cross-industry, cross-border technology collaboration partner to Taiwan's industry. Since then, he has been instrumental in many bilateral trade and industry collaboration facilitations, market research and analysis, market entry advisory, and related business operation based in India. He had represented the industry in many forums, including governmental, non-governmental, and other stakeholders. He had been instrumental in various state government policies of most of the South India states as part of various committees. Today, he's going to give us a talk titled Technology During COVID-19 Pandemic in India, a Smart City Public Health Perspective. Let's welcome Mr. Krishna.
Thank you. Thank you for the introduction. And I'm clearly audible. Being the last panelist, I'll try to create, it as interesting as possible. Won't take much time. So the slides, please. So as we all know that this novel coronavirus created pandemic has triggered an unprecedented demand for digital health and smart technology solutions, and has revealed considerably successful results, especially for countries like India, as one of the major motto of public health under the Smart City mission is to make healthcare within the ready reach of common man and also make it affordable. So technology adoption is showing successful results in areas such as solutions for population screening, tracking the infection, prioritizing the use and allocation of resources, and designing targeted responses. The 5 major segmented approaches in India for tackling the COVID-19 pandemic and wherein technology played its role as are shown in the slide. So next slide, please. As we all know that the technology cannot as such prevent the onset of the pandemic. However, it can help prevent the spread by educating the public, warn them what to do, what not to do, and how to do, and empower them on the ground to be aware of the situation, thus noticeably reduce the impact. During a pandemic, a clear messaging to the public is very critical to make sure they are well informed and reminded to use appropriate precautions. In India, as an endeavor to raise maximum public awareness about COVID-19 disease and educate the public in India, all online as well as offline media were utilized. So social media sites such as Facebook, Twitter, Instagram, etc. ran their own awarenesses. The Ministry of Health and My Government portal, which is a government citizen service portal, initiated a helpline number in WhatsApp for public to get COVID-related queries answered. However, the very attractive or the very important aspect is a maximum reach that actually went to all the citizens was a 30-second audio clip used as a caller tune on mobile phones. So many state governments had their own reach outs in terms of various apps and other platforms. So next slide, please. So in effect, like no wall was left vacant in terms of creating awareness to the last man in the country. Next slide, please. India is one of the countries which went into a complete lockdown at the very initial stage of infection itself. So it was almost a sudden lockdown which created many havoc. So as for a city administration, there had to be multifold surveillance. One for the law and order situation demanded as part of the lockdown, and the other one on disease surveillance. The contact tracing, widespread testing, quarantining is being coordinated under the Integrated Disease Surveillance Project and the decentralized state-based disease surveillance program established in 2004 with the National Center for Disease Control. An efficient government surveillance program requires collection and processing of large-scale personal data, including sensitive health and location data. This was raised crucial concerns relating to protection and privacy. The lockdown is a very blunt and crude instrument. What was in need was a robust disease surveillance backed by the maximum testing. This is where the smart cities could leverage most of its existing infrastructure added by the ground level data to be put on various predictive mechanisms. So some of the methods to collect these data and do the surveillance was, you can see in the picture shown there. Next slide, please. So as a result of this, the humongous amount of data backed with real-time visuals flooded into what is called as the COVID war room, specially created at almost all major state capitals, district headquarters, etc. So there is also a national level COVID war room set up in New Delhi. This is where about 30 odd people, that includes doctors, data analysts, technology specialists, and public health professionals from various agencies, have been collecting and analyzing the kind of granular data from the states to identify the gaps or forecast a sudden surge in cases and warn the states to take action accordingly. So one team, there are different teams. One team tracks the growth of cases and deaths, doubling time, this statistical data. The another team keeps a watch on the availability of infrastructure down to the district level. A third team looks at future projections to assess the state level preparedness and shares this data with the state every day. A fourth group looks at the projection to see where the numbers are headed. And the last team tracks global trends vis-a-vis India and sets deliverable goals for the states. There's also a dashboard tracking social media, identifying fake news and information that needs to be relayed to the states, among other things. So these war rooms works like a central nervous system whose wide range of operations include providing user-focused solutions, combating misinformation, supply chain management, application supporting health workers, community engagement platforms, support knowledge management, so on and so forth. Next slide, please. The patient identification is mainly from large-scale testing being conducted on ground. However, various other sources trigger probability, which then be used to do further testing or identification for zones. Data from hospitals, medical stores, and various apps were integrated to the what we call as ICCC, that is the Integrated Command and Control Center mechanism. From contract tracing to creating buffer zones around the COVID-19 clusters, India is using mapping and location tracking technology to fight the pandemic. So GIS is the system designed to capture and analyze data using spatial trends. In the context of disease surveillance and monitoring, it integrates data such as the area of outbreak, population health, and available infrastructure to identify the population at risk. Many startups have also come together to build apps and dashboards that track how close we have come to infect individuals or disease hotspots. All these apps use geofencing to track or Bluetooth, to track infected individuals. And there's also, in a developing country such as India with a very high population, the POC tests and devices play a vital role in the healthcare system, especially at the time of the pandemic such as COVID. Mainly because it is estimated that, if you look at the proportion in India, there is one doctor for every 1,666 people. And the same case, like 1.3 hospital beds for every 1,000 people. So in this way, India is a resource-limited country in terms of public healthcare. So next slide. So developing a new tool takes time and has a risk of failure. An alternate approach is to repurpose already available innovation. This tactic can significantly reduce the lead time for deployment, especially important during situation like the fast-moving crisis of COVID. So I've listed some examples, like Apollo is a large group of hospitals in India. Their radiology department integrated with what's called Zebra Medical AI platform with its COVID reporting center, which reviews and analyzes all the CT scans from across Apollo hospitals in the country. The AI platform will be integrated into Apollo Radiology International's COVID-19 reporting center to automatically detect and quantify suspected COVID-19 findings based on a machine learning patented algorithm and the CT scan analysis. The same way, there's a company, Meet Cure AI, is a company in Mumbai that develops artificial intelligence algorithm to interpret radiology images, a key tool in the fight against another highly contagious pulmonary disease, that is tuberculosis. So this Cure AI automates the interpretation of chest X-rays used as a primary screening tool and followed by laboratory confirmations, significantly reduce the time to diagnosis when qualified physicians are in short supply. The results are achieved in about a minute. So they have retooled this innovation initially created to detect TB to detect the lung characteristics indicative of COVID-19. So the same way, the RayBay is a radio wave-based breathing monitor for babies. One of the indicators used to monitor COVID patients is the respiratory rate. A normal human being at rest takes between 11 to 21 breaths a minute. For a COVID patient, it is 24 or more. And since their technology is a radio wave based, it can monitor patients from a safe distance. So these capabilities can assist in monitoring progression of the illness and help doctors manage the patient care. So next slide, please. So we talked about the analytics, the video analytics, virtual fencing, etc., which trigger breaching of social distance norm and crowding, etc., which in turns calls for authority interfering to manage. So similarly, there has been many innovations largely initiated by the startups with devices, kiosks, equipment to control the transmission. This was mainly at a stage when the India was reopening to from the lockdown time. So the devices morely are wearable devices which can be integrated into tags or tickets to give a beep reminding from social, for social distancing, automatic entry management to any premise to facilitate distance, virtual queue, etc., etc. So there are also robots to providing sanitizers. However, mostly prevalent is products looking like kiosks having a camera with the ability to check body temperature, a sensor-based automatic sanitizer dispenser, a processing unit for video analytics, including face recognition and mask detection, supported by a dashboard with which alerts the notification. And some of these kiosks can also be connected to the government system, wherein like the alerts can be provided to the authorities. Next slide, please. So this is one of the much talked about app that was kind of a viral in India. So this is called Arogya Setu. It's an open source COVID-19 contact tracing and mapping self-assessment mobile app. This was developed by the National Informatics Center, which comes under the Ministry of Electronics and Information Technology, Government of India. So the purpose of this app is to spread, not just to spread awareness of COVID-19, it also connect essential COVID-19 related health services to the people of India. This app augments the initiatives of the Department of Health to contain COVID-19 and shares best practices and advisories. It also acts as a tracking app, which uses the smartphone's GPS and Bluetooth features to track the coronavirus infection. So with Bluetooth, it tries to determine the risk if one has been near a COVID-19 infected person by scanning through a database of known cases across India. So using location information, it determines whether the location one is in belongs to one of the infected areas based on the data available. So next slide, please. So even though everybody was talking about the telemedicine, so in India also the telemedicine has been there for a long time. Its importance is largely realized during this time, and that too, the telemedicine was more or less being used by the urban population. But during the lockdown, the healthcare startups reported about 500% growth in online healthcare consultation, and 80% of them were first-time users, and 44% of them from the non-metro cities. So this is based on various apps such as Practo and other things, which is very popular and prominent in India. And as per the Future Health Index 2019 report, it ranked India amongst the leading nations in the adoption of digital technology, with 88% healthcare professionals using at least one form of a digital health technology. So clubbing with the facility with what I have explained in the mentioned in the left-hand side, the government policy, the new guidelines by the ministry, and also the e-pharmacy being identified as an essential service, boost the telemedicines, which primarily will be a good thing for India in future. So there are other aspects from the smart city perspective that we need to relook at, because in the smart city mission, only around 2.3% is devoted to health and education, whereas area development, which takes the major share of 23%, followed by the urban transport 40% and water supply 11%, housing 9.9%, so on and so forth. I think the COVID will facilitate, the situation will facilitate a refocus to the public health with increased adoption of technology. And as Dr. Saha was mentioning about the digital health mission, like this will definitely be a spruce or be a guiding force for India to transform to the next level of public health from a smart city perspective. So next slide, please. So that's it. Thank you. It was a quick compiled point, and we'll try to answer any further clarifications.
Okay. Thank you, Mr. Krishnan, for your presentation. And thanks to all the delegates above. This comes to an end for the presentation session. Now we are going to begin our panel discussion. Let us now invite Professor Xu again to kickstart today's panel discussion for healthcare session.
Okay, thank you. So now we are going to start our panel discussion. Thank you for all the speakers, wonderful presentation. I have already picked up several keywords so that it will be easier for us to do the discussion. First of all, I would like to address the keyword of interoperability of PHR, personal health record. I think several of the speakers, panelists, is already addressed that. We have independent silo, we have fragmentation in the data, and we would like to, several speakers also I think that the data integration is very important. And from Japan, we see this wonderful PHR system for the APP, and we like to integrate data. So my first question I would like to ask the panelists is like, how do you think and you experience in your country the data interoperability of the personal health? Can you share some of the experience in your country? I would like to ask first maybe Dr. Miki, you want to give us some experience in Japan regarding the interoperability?
Okay, thank you. As far as I know, in Japan, the interoperability of the healthcare data is not fully guaranteed. So, for example, electronic medical records were stored in the hospital, and the system is developed by different vendors. So they are not interchangeable, and they cannot be transported to the other places or to the individual patients. So I think there are a lot of tasks that we have to solve in order to utilize these healthcare data for smart city purposes, such as creating new services for citizens.
Okay, thank you. Of course, interoperability is always very hard work in any country. So how about Dr. Shah in India? How do you think?
Yes, as I said, interoperability in a large and complex and diverse country like India is definitely a very difficult goal to achieve. Nevertheless, it is a goal worth targeting, so to speak. So through the National Digital Health Mission, the approach that we have taken is that let us identify the most critical data that is required to make the digital health platform operate. And if you saw my presentation slide in the architecture diagram, we have identified data pertaining to health professionals, health facilities, diseases, pharmaceuticals, pharmacies, so on and so forth. So these are the 6 or 7 critical areas that we have identified are fundamental to having a digitized platform. And the most important step to achieve interoperability is to define standards for these data and registries, and also metadata standards. So the 2-step process would be to define the standards across these priority data areas, number 1. And number 2 is through a series of effective governance mechanism is to enforce those standards, because typically what happens is that the ministries and the different states and territories that India has, they start building their own applications and systems without looking at the standards, which is typical human behavior, because I want to do my own thing. So what we are trying to bring is in that discipline of thinking that there is a standard and that standard needs to be followed if you really want to participate in the digital ecosystem that we are currently building through the National Digital Health Blueprint.
Okay, thank you. How about Mr. Krishna? You have any suggestion and experience?
Yeah, I don't have to add much as Dr. Saha mentioned, but one aspect, India is a late entrant in terms of adopting the data protection related regulations. So I think moving forwards, the standardization and as Dr. Saha was mentioning, the federal system in terms of health comes under the state, wherein the data interoperability could be an issue, and which probably would be looked at the National Digital Health Mission in terms of addressing it.
Okay, thank you. So also in Taiwan, I think we already built so-called medical record exchange network for many years. And also in Taipei City Hospital, you already built a very strong internet to exchange our medical record data. So can you share some, Dr. Chu, share us some experience?
Yes, we really use this opportunity to connect all our medical records, especially those X-ray, CT scan, MRI, all together. So all the people's radiological film can be seen by any doctor you visit. I think it's very convenient and efficient for people to looking at different doctors. I was particularly interested in our Japanese expert, Mr. Miki's topic about using the so-called PHR to improve our frailty during this COVID period. That's a very impressive thing. I think it's a very, very good idea because in our hospital, for example, I think also in your hospital, that we use like this facility for integrated treatment of diabetic patient. And I think the framework is almost the same as you described. And just create a new idea and using at a different situation, it's very useful for our human being, I think. Thank you very much.
Okay, thank you, Dr. Chu. Yes, I think the infrastructure is very important. Okay, infrastructure of data, infrastructure of system, and infrastructure of business. So because of the this COVID-19 epidemics, so that also drive us to speed up the development of ICT used in healthcare. So just like we see several of the speakers. So the second keyword I would like to address is telemedicine. Include everything like our Japanese speaker and also our Indian speaker. Telemedicine, because of this non-contact medication we need to provide in this epidemic situation. So how about the development of long distance and telemedicine technology in different countries? How about Dr. Chi give us some example you used in Taipei City Hospital?
Yes, it's also a similar experience like we experienced during this COVID period. That I think the most barrier to overcome is the legislation.
Legislation.
Yes, because we have very good technology. We have very experienced doctors and technicians to use this telemedicine, and it's very mature. By sending message, by integrating your medical record, it's very good idea. But in Taiwan, frankly, in the past only can be used in the very far mountainside or island, not in the city. So this time we have the opportunity to be permitted by the government that we can use during this COVID period.
So do you think we are going to have this kind of regulation?
Yeah, I hope so.
Oh, okay.
Because even in the domestic cities, some people living in the high floor, it's very difficult for them to come down and to visit the hospital.
Yes, yes.
Yeah, so I think for a good regulation or legislation, that we can provide better service for this handicapped patient.
Okay, thank you. So how about Mr. Krishna? You have any experience on the telemedicine?
Oh. Yeah, the telemedicine is there for quite some time, but the peculiar thing with India is there are different kinds of medical practices which is prevalent in India. So it's not just the allopathic medicines, but when we talk about accessing the medicine for the rural segment, there are so many aspects one need to look at it. It is the system of medicine. Then, of course, close to 70% of the India is in the rural segment. So infrastructure, one will be something which we need to look at. And even in case an infrastructure is built, the doctor and the patient has to be in the same wavelength. Like some of the parameters that the doctor asks needs to be understood by the patient. So there's also an educational level connect that need to be brought in that aspect. So wherein there are solutions, for example, like India has a very wonderful system of public health centers which are there in every nook and corner. And one case which actually we saw in the past year when the Nipah virus came in a state called Kerala was the success of the community nurse system. So a nurse from a locality with a required educational background is identified as a mediator, and she goes to this rural segment, and she can be the middle person in interacting between the patient and the doctor. So in those cases, I think in that perspective, it can definitely be a success. And another question probably could be in terms of availability of medicine. So there has to be a mechanism in terms of supply of medicine to this rural segment. So that there are, different aspects to be looked at it. But I feel, if you ask me to put it in a one sentence, I feel currently the COVID situation has improved our goal or our approach towards the telemedicine in the rural. So I think that's a positive thing that we can take from this pandemic situation.
Okay, thank you. Yeah, indeed, we have lots of problems need to solve, and hopefully the COVID-19 situation can, really driven us to speed up the development. And also, how about Dr. Shaha? You think how about regarding the regulation of these infrastructure of telemedicine?
Yes. So as Prem was talking, the idea of telemedicine has been in India for a few decades now. So people are not new to this concept of telemedicine. In fact, in the past 7-8 months, as I've said, the citizen, even in the rural area, they have become more open to remote consultations. But as as my other colleague speaker was talking about, the change that is required is a enabling regulation. That is very, very important, because telemedicine or remote consultation is not a technical problem to solve. That was solved 20 years back. So it is not an issue from a technology perspective. I think it's more of a regulation issue. So for instance, in India, in the past 2 years or so, and Prem will agree with me, we have had a massive growth of, for instance, e-pharmacy. But what happens is that whenever these e-pharmacy stores or apps are becoming more and more popular, the physical brick and mortar pharmacy stores are seeing that as a threat rather than actually as a complementary mechanism or a complementary channel to distribute medicine remotely or to distribute medicine to areas which are not difficult to access areas, because India has many such areas where access is very difficult. So these are, from my perspective and from an India context, technical solution to telemedicine and remote consultation is not the issue. It's in terms of addressing the ecosystem requirements. It's in terms of addressing the regulations to make it possible. So that's a priority that we are trying to address at this point.
Okay, thank you. So Dr. Miki, can you also share some telemedicine or telehealthcare, just like the app you developed in this trial in Japan? So give us some perspective.
Okay. As far as the regulations, enough is talked about already. So I would like to mention one important thing, which is not all citizens are able to use the telemedicine or even the smartphone. And I think in Japan, only like 70% of the people have smartphones. So technology is there, but people aren't catching up. You can't forget that part. I think, and also to further grow the field of telemedicine, I think you should, or the private vendors should maybe develop some IoT devices such as maybe stethoscope or saturation monitor, so that the patients, they can use that IoT devices and put it on the surface of their body, or maybe take a photo of the skin or something, and doctors can refer to that digital information and make proper diagnosis, or maybe lead to the right treatment or something like that.
Okay, thank you, Dr. Miki. Okay, because of the limit of time, I will address the last question about global and collaboration. I think also addressed by several speakers of our panelists. Yes, okay, first of all, I think we all have different efforts in different countries, in different regions, and to develop many information systems to solve the problem that we are facing in this COVID-19 situation. So in Taiwan, as we represented by Dr. Huang, the commissioner, so we also developed many ICT systems to control, to report the COVID-19 situation. And one of the very surprising system is we can really do a real name registration masking vending machine. So that's also surprising me. But anyway, it is not the magic. It is just infrastructure. Okay, so in Taiwan, I think we will very like to share our experience to other countries, to other experts. So how about Dr. Chi? How do you think in the future we can collaborate with other country, other area? How do we share our experience regarding this ICT technology using in COVID-19?
Yes, that's a very good and a very big question. I think cooperation is here. Yeah, this situation, this meeting, that's very good. Maybe something like the idea we shared today will create more idea or renovation about our technology. And something like we also open-minded to those foreigner or even to our different subspecialties. For example, in our hospital, we open our wards, patients' wards, ICU, and OPD for those technologists or computers company, and try their devices in our hospital. Of course, after passing through the IRB and essential agreement. So I think in the future, the cooperation not only between different medical or the computer science and over the different countries is very important. Yes.
Okay, so I think we also have different association like NGO, so we can really work together to solve a lot of problems. So how about Dr. Miki? Can you give us some suggestion to the future collaboration?
Okay, I think the first step would be to set the standard for the interoperability of the healthcare data.
Oh,
so
great.
That I don't know, it can be anything like maybe like HL75 or something, but we just have to make the rule and then make sure that everyone follows that rule, so that data description is the same and we can all use that data internationally. So I think this is the international effort that we have to make in near future.
Okay, thank you, Dr. Miki. That is a wonderful suggestion share data. So as I know, it's very difficult to, especially for health care and medical data, to share with different, even different hospitals. Okay, nevertheless, we want to share data between countries. So, but because of this COVID-19 situation, we can see internationally we do share data. Okay, people travel from this place to other place, and if they are tests like positive, then we will alert internationally. So that is a very good collaboration to start. So we do share data. Patients' data between countries. That is very good example. So how about from India, our friend from India, Dr. Shah, please give us some suggestions.
Yes, in fact, the National Digital Health Platform that I, briefly described is basically, as I said, it is an open platform. We encourage health tech startups. They need not be Indian startups; they can be from any country to provide solutions, to provide apps, and to be part of that platform. But as I have mentioned previously, and also reiterated by Dr. Mickey, what we are trying to define is identify the priority areas where data is important, define the standards, publish the standards so that the standards are available for everybody to follow. Because without the standard, it is very difficult to provide any kind of interoperable collaborative solution and to make the digital platform work. Because I think all of us agree that in today's world, be it a digital platform for any domain, be it health, be it agriculture, be it education, be it commerce, whatever it is, it depends on data. And therefore, the most important and critical layer for us to address to enable collaboration is to address the data layer. Without that, it is not possible. And this is something we need to tackle at a international level. And as you were introducing me, I am doing some work with the ITU to create those data standards that can be used across multiple sectors and multiple domains.
Okay, thank you, Dr. Shah. Yes, if we want to collaborate and if we want to change data, the interoperability, the standardization of data is very important. And I would like to share some experience in Taiwan. I'm representing the Taiwan Association of Medical Informatics. We also developed a blockchain platform for personal health record, and it has been announced in Southeast Asia area. So also in India, last time we announced this platform in Sri Lanka actually. But anyway, that is association. We call this AHIN. Maybe some of you already know is this Asia Electronic Information Network, Health Information Network. So that is the Taiwan would like to share this freely of this platform to any other country would like to use this blockchain PHR platform. It's already compatible to use. It's already standards HL7 file formatted, so it's already a standard, and then everyone can try to. If you are interested, you can call to us. Okay. Finally, how about Mr. Krishna? You want to share our suggestions? How do we collaborate in the future?
Yeah. For the time moment, keep aside the data interoperability. But I think there are quite a lot of scope in terms of technology transfer, which India and Taiwan can do, which as part of the Foundation for Commerce and Culture Interchange, we are also keeping options open for the Indian industry to collaborate on the medical electronic segment. So one aspect clearly is that of the drone technologies, because as I told, providing medicines to the rural area is something which needs to be on a sustainable and a continuous basis, where for the first time in the state of Maharashtra, they tried as a trial model of providing the medicines to the rural area. So there are other, for example, in my presentation, I talked about Zebra Medical AI, which is a a Middle East-based company which collaborate with Apollo hospitals in providing the technology. Similarly, the Cure AI is an Indian company which developed the concept, which is providing that solution to some of the hospitals in countries like Thailand, Indonesia, and even the African countries. So I think there is quite a lot of possibility for the collaboration in terms of technology transfer in the medical electronic segment.
Okay, thank you, Mr. Krishna. So I need to ask. Okay, we do have time limit. So I would like to thank you all the panelists today to join us this session of CTalk. I think we will have the more discussion in the future, and I'm very fortunate to join this session, and so happy to meet our international guests from different countries. So I think I will end the session here, and thank you again. Bye-bye. See you next time.
Thank you, Professor Xu and Dr.
Bye-bye.
Chu, for your closing remarks.
Thank you.
And our deepest appreciation goes to Commissioner and all the delegates for participating in today's virtual CTalk session. We hope to see you again here at the same time tomorrow for CTalk Innovation Online on how coronavirus sparked a wave of innovation in humans' life. See you then.
Sometimes, yeah, great. Nice to meet you. Yeah,
Thank you.
I do have. So we have the connection, right? So we do have talk about the future collaboration. So future collaboration, I will try
Same platform.
to call you, and if you would like to share some experience, and I'm willing to share our blockchain PHR platform for all the other countries people. Yeah, thank you. See you.
Great.
Bye bye. Bye bye.
Thank you. Bye bye.
Bye-bye.